The fact of the matter is, they are putting pressure on us to go through and do things in a manner which 3 years ago, it was okay to allow the patient in the hospital. Now they go through and retroactively apply that rule. Other payer strategies. Heritage Victor Valley. They're not paying observation correctly. So we have to go through and argue with that. That's another administrative time. We have to pick up, go down to Victor Valley, sit across the table, and spend hours talking about this. Mary Beth Rasmussen, who's our Director of Patient Financial Services, spends a lot of time on the phone arguing over these points. Time that we could go through and spend doing other things, but you have to go through and try to get your money. We're collectors at heart. And there's another one. It's a small one, only $100,000. The Sheriff's Department, throughout the state of California and up here, turn around. If a person is arrested and they go to jail, they book them, and then the Sheriff's Department transfers the patient to the hospital, then the Sheriff's Department is responsible, County Assembly is responsible for the health care. It's only $100,000, but if the patient is not booked and they're transported to the hospital, the patient's responsible for the bill. Many of these people are uninsured. Where does that go? It goes to bad debts. So it's another little ploy. It's like what Senator Proxmire said. $100,000 here, $100,000 there, pretty soon it's $1 billion. And that's what's happening to us as well as other hospitals. Brenda Boss Family Resource Center. We're about $3.9 million what the budget's going to be. It's going to be, it goes back and forth a little bit on that. But it's going to be, I believe, a really, it's going to be a useful product because we're moving to the outpatient services, and that's exactly what that facility is going to do. It's going to treat a lot of Medi-Cal patients, but the reimbursement for Medi-Cal for rural health care is very high. It's very, very profitable, high margins on it. That's basically because in our rural communities, we are higher with Medi-Cal patients, and that's the way the government goes to make sure that the patients in rural America are properly treated. The use of local contractors.
Be sure and let Megan and Renee know.
Oh yeah, right, exactly, right. Thanks, Rick. The use of local contractors. The two contractors that bid the project, which was Bear Valley Paving, and there's an installation company which I can't remember the name. The Bear Valley Paving was awarded several contracts, approximately 10 contracts for various type of projects, approximately $660,000. The other contractors were contacted, but through one of several ways. We advertised in the Grizzly, we advertised on K-Bear, we advertised Rim of the World. Also, plan rooms. This is where you contractors have policy or plans put onto the online, and they go through and access it. This is where they normally get jobs. And also, we went through, and J.P. Montero, who is the principal for Bear Valley Paving, made an announcement at his contractors. Unfortunately, the contractors did not go through and bid. We think it's because it's a prevailing wage project, which is significantly higher than what they normally pay their workers. The bonding, which is very difficult to get because a lot of the contractors have issues right now because of the down economy. You know, we all talk about shovel jobs in the pipeline and shovels and everything, but the fact of the matter is, these guys can't qualify for the jobs or public works projects. So it's a very convoluted process. Certified payroll. Payrolls must be certified. Money must be in the bank. And you have to go through and prove it. First Mountain Bank reviews the invoices for J.P. Montero. Plus, we have to go through and audit that, the district does, to make sure that there's compliance. And the last one is there's an apprenticeship program. There are requirements on the job for apprentice. And a lot of the folks up here with the contractors, this is an onerous process. So they didn't go through and bid, and that's one of the issues we have. But so we did go through an attempt to go through and bid the project. At this point, what I'd like to do is ask Renee Marquez to come up and talk about the Brenda Boss project. And Megan, excuse me, I'm sorry.
down a little bit, because I'm a little bit shorter than everybody.
Okay, so we've heard some of the bad news for healthcare and for the healthcare district from Bruce and Ray and Rudy. And my name is Megan Metters, and I am the program director of Bear Valley Community Healthcare District Mom and Dad Project.
And my name is Renee Marquez, and I'm the director of outpatient clinical services.
And we kind of just wanted to clear the air a little bit on the Brenda Resource Center. Renee and myself, along with our staff, are out in the community very frequently, and we're getting asked a lot of questions. If this is the direction that healthcare is heading, why are we building this building? So we are up here to kind of clear the air, be transparent, as the board spoke about earlier, and just kind of answer some questions regarding why we're building the building and where the funds are coming from.
Outpatient clinical services are essentially two areas that we are looking at for growth and enhancement of current services that are available. One of the ways that healthcare is going in general is
Renee, make sure you speak directly in the mic. They can't hear you back there.
Sorry about that. Let me switch forward. How's that? One of the ways that healthcare is going in general is to outpatient services. I don't know when the last time you folks went to your doctor and really got an opportunity to see your physician. And that's wonderful. Physicians are the root of where healthcare starts, and we are so appreciative of them. But one of the ways that outpatient services is going is to provide care at a more financially conscious type of way to do it. And by that means, we're talking about providing care with nurse practitioners and physician's assistants, which probably a lot of you do see when you go to your providers. In this case, with outpatient clinical services, through the clinics, we have the opportunity to provide services on a global reimbursement scale, meaning that when you walk in the door, your care is provided, and our reimbursement through Medi-Cal in particular is really quite high. It's actually almost seven times that of what your typical provider who receives Medi-Cal gets. And just for transparency's sake, at the Family Health Center, currently every patient that comes in that is a Medi-Cal patient, our reimbursement on that patient is approximately $260 per patient visit. That's per visit, and that's all encompassing. Our rural health clinic is approximately $198 per patient visit. So that is a growth area that we are seeing, and if anything, it's the one area that we're not seeing that reimbursement is actually being cut. Over the past year, we actually got a bump in our reimbursement rate because so much of services is now going to an outpatient service provision. So what we would like to do in order to enhance and also support the district in general is to be able to supply more services through the clinics. Currently at the Family Health Center we have 6 rooms. On some days we have 4 providers in 6 rooms. And that gives each provider sometimes 1 room, if they're lucky 2. So in this way, we can go from providing 6 rooms in one facility and 3 at the rural health clinic. We have the potential to now go from 9 rooms to 15 rooms. We're also looking at an extension of service hours, and this will be happening very quickly. We're looking at May 6th for an extension of service hours from 8 a.m. to 8 p.m. with weekend hours as well for our Saturday hours. So what we would like to do is not just because we're self-sustaining, meaning that we can pay our bills from what we make in a profitability standpoint from the clinics, but we want to make enough money or be able to be financially stable to also support the district, because we are under the umbrella of the district, and that is our goal, to provide community service, not just to Medi-Cal patients or Medicare patients, but the nice thing is you as community members have the availability to come in and see one of our nurse practitioners like Sam Som or Melissa Starica or Joyce Kasuma or our new pediatric nurse practitioner Suzanne Chapin, and see them. And when you come in, you as a community have the opportunity, if you pay at time of service, to see that provider for your basic visit for $30 for a patient visit. That's amazing. How many of you can really see your provider for $30? And so we're seeing a huge influx of self-pay patients because even if you are covered by an insurance, you have the opportunity to come here to our hospital, be supportive of the hospital, get fabulous patient care done and quality services right here in your own backyard. And that's just by staff who really want you to be there, and by a community that we appreciate that you provide support to us as well. So we're really excited about this. We want to help the healthcare district grow. We want to help the healthcare district provide quality services to people that live up here on the hill. One of the other nice things about it too is 70% of the patients that we administer services to live on this mountain. So this is care that's provided specifically to the people that live up here. And that's our goal, is to enhance those services and provide quality care to everybody that lives up here. Not just the patients that, yes, we appreciate the financial stability that they give to us, but the people that really live here. So thank you.
Real quick, in addition to that, the Mom and Dad project is grant funded. We're at about 60% right now grant funded. And in the 13 years that the program has been around, we paid rent to buildings in Big Bear somewhere to the tune of $450,000. We would like to pay rent to something that we're going to own, something that's going to sustain. So thank you to the foundation, who has actually done a lot of fundraising efforts for us, which have allowed us to go out and obtain matching grants. Our biggest funder, First Five, is going to be giving us about $30,000 to $40,000 next year. We have a couple of grants on the table right now with Department of Behavioral Health that'll open up our opportunities in this valley, as Renee said, for people to come for different services. We are looking to rent out space in every corner of that building so that it's paid for, so services are being offered here in this valley for people that are in this valley. Not just medical, but educational. First Five offers parenting education and a resource center. We're looking into Department of Behavioral Health as an additional resource center services. We're looking at partnering with Lutheran Social Services, with Dubs, and creating a one-stop family resource center. The Mom and Dad Project currently houses WIC, which we've never had up here, and in the time that we've had WIC, we've seen about 3,500 people come through our doors in a year and a half. So these services all pay rent that will contribute to the rent of this building. So like I said, we just kind of wanted to clear the air on where the money's coming from, where we're planning on finding more of it, and we really thank you for your support.
Thank you, Renee and Megan. And we will take questions in a couple of minutes in case you have any questions about the Brenda Boss Family Resource Center. And as they said, part of our mission tonight is to answer any questions that you may have. But I will say, and you will hear more about it in the presentation tonight, as we're talking about shrinking services at the hospital and fewer inpatient days and fewer services in the hospital. One area that is growing is outpatient, is the Family Health Center, and we're getting paid well. So as we plan for the future and the future of a healthy Bear Valley Community Healthcare District, one of our key strategies is to grow our outpatient business, grow that Family Health Center, and I believe that the new building will be a tremendous asset to the district and to this community, which you will be very appreciative in the growing years. And it will allow us to utilize the space in the existing building where we plan to grow more outpatient services. And we're looking at moving our physical therapy department into that building so that we can grow it. Physical therapy is another area of growth for us in outpatient services, as well as opening up spaces for doctors and visiting doctors for the community. So we'll be happy to take any questions you have in a couple of minutes about the Family Resource Center or anything else under Rudy's presentation. And before I leave Rudy's presentation, a couple of things. One of Rudy's early slides talked about surplus and loss for the district. And you remember the bar charts that he had going across the screen. They went from well above the line to below the line. Below the line's not good. In the last 3 years, he shows on his bar graph annual losses of $700,000, $800,000 In the current year, he's projecting a $2.5 million loss. In this next section, we're going to talk about the parcel tax that supports the district in an upcoming parcel tax election. And the thing that I would want you to remember is just imagine what that bar graph would look like if we did not have the parcel tax. And we'll talk about to the extent that is crucial to the success and survival of our district. We do have a parcel tax that supports our hospital. You're probably aware of that. Every property owner that lives within the district boundaries of the Bear Valley Healthcare District, which is primarily the Big Bear Lake region, has a portion of your property tax bill each year comes to support the hospital. It's $45 per year. $45 per year is really a bargain to keep a good hospital locally in our community, and you might think of it as very inexpensive insurance. For $45, you're keeping a hospital in the community with a 24-hour-a-day emergency room and all of the supporting services that support that hospital, so that in the case that you ever need it, and like I like to say, all of us in this room are probably one slip on the ice or one heart attack or one motor vehicle accident away from needing that hospital. You'll thank that $45 that you paid if you keep the hospital locally in the community. The parcel tax was originally voted in 1994. It is used to support the operations of the hospital. It brings in $1.1 million per year. So again, think about that bar chart and where it would be if you took away $1.1 million off of the bottom line. This year we'd be looking at $3.5 million loss, and we would have been close to $2 million loss for the last 2 years. And we would be obviously in serious trouble. Next year, we're anticipating that there will be a parcel tax election to ask you and ask the voters of our community to support a renewal of that property tax. If not renewed, it will expire on June 30th of 2015. The reason that we're looking at doing a parcel tax election next year in 2014 is because it takes 66 2/3% affirmative vote in order to pass a tax in California. I'm sure you're aware of that. 67%, it's a pretty high bar. In the event that we would be unfortunately unsuccessful in passing a renewal of the property tax, if we did the election next year, we'd have a second chance to do it again and to try to get the last remaining percentage in order to get us over the bar. Hopefully that won't happen, but you will hear more tonight about the critical importance of that property tax. And this is just to give you an idea of the tax support that comes in to support our local hospital. It actually includes, this is not just the parcel tax, but this also includes the ad valorem tax that comes in to support our hospital as well. It's about $1 million each that comes in to support us. This is a breakdown which shows you the bottom line. The blue on the bottom is the parcel tax. The red in the middle is the general tax, as you can see, and then there's a green on the top for redevelopment agency. And the total 2013 projected is about $2.1 million to support the hospital. And with that, we will pause and take more questions. If anybody has questions about the profitability of the hospital or projections for the future, parcel tax, Brenda Boss Family Resource Center, anything that you'd like to ask about at this point in time before we continue. Yes, Dr. Fagan.
One of the government cutbacks that everybody is not aware of, and he raised as a point, has to do with observation patient reimbursement. And what the federal government has dictated by its ICD codes and whatever as to whether we admit you or you're an observation patient at our facility. Can you elaborate on that a little bit?
Absolutely.
That total is 1.2 million without that as a loss, so it adds
Yes, and thank you for that, Dr. Fagan. It reminds me of something else I was going to mention. When I look at the profit and loss statement of the hospital, if I look at the top line and look at the bottom line, it actually doesn't look too bad. Our inpatient census is down, our inpatient activity is down, but outpatient is outperforming at a phenomenal pace in our outpatient revenue. Rural health clinic, family health center, diagnostic imaging, emergency department, laboratory, all of our outpatient services are outperforming by a tremendous margin, including observation days, which is an outpatient service. And outpatient is making up for the loss in inpatient revenue for the facilities, to the point where actually through the first 7 months of the current year, we are above budget on revenue. If you look at the bottom line on Rudy's profit and loss statement, the expense side, we're actually doing pretty well as well. And we're doing a pretty good job of managing our expenses. If you look at actual expenses through the first 7 months of the year versus budget expenses for the first 7 months of the year, we're below budget on expense. If you take into consideration revenue above budget, expense below budget, that's pretty good news. And most business owners in the room here would probably be pretty happy about that. But the phenomenon that Dr. Fagan is talking about and Rudy was talking about a few minutes ago in the government cutbacks, I might want to go back to that slide actually. This is the middle part of the profit and loss statement that we look at. We have revenue, we have expenses, but we don't get paid what we charge for our revenue producing services in the hospital. We don't get paid 100% for inpatient services or outpatient services or skilled nursing facilities. Everybody gets a discount, basically. If Medicare doesn't pay us what we charge, Medi-Cal doesn't pay us what we charge. On observation days, and by the way, this morning we had 3 patients in the hospital. All 3 of them were observation patients. Observation patients in the hospital, they look just like hospital patients. They don't look any different. They're occupying the same bed. But what's this slide say? We get paid 15% of our bill charges for observation days in the hospital. So it's the middle section, which we call contractual allowances or deductions from revenue. Deductions from revenue is what Blue Cross and Blue Shield and Medicare and Medi-Cal and Heritage Network and everybody else doesn't pay us due to the discount. It's the discounts that they take. And when you take the discounts, and our discounts now include $425,000 for Medi-Cal deductions for skilled nursing, 15% of observation, recovery audit contractors, $440,000 off the top line, and another $500,000 off the top line for AeroCare. That's where our problem is. Our problem is we don't get paid for the services that we provide. And that's what Dr. Fagan's talking about. That's what Rudy was talking about. There's not much we can do about that. And we are going to Sacramento and appealing to the legislature, and there's 2 bills in the legislature right now asking for the state of California to repeal AB 97 and not take those draconian cutbacks off of the skilled nursing facilities that are going to close skilled nursing facilities. We are meeting with the Board of Supervisors later this month and asking them to enter into a certified public expenditure agreement so that we can at least get paid for emergency services provided and not have almost 100% write-off for AeroCare. We anticipate the County Board of Supervisors is going to support us, will approve the CPE agreement so that we can get paid for emergency services. But our challenge as a hospital is to manage our expenses, but also to manage the deductions from revenue. And that's what's killing us. Any other questions? In the back there, you want to come up?
Can I just tell you some I'm not sure
Okay.
I'll get up there. When we go to critical access, will that have any effect on our reimbursement for observation patients?
The question was, when we go to critical access hospital designation, will that improve our Medicare reimbursement for observation? And I think it will. Right now, what we're getting paid is what we talked about a moment ago, 15% of bill charges. At least we'll get our cost. And most hospitals find that in the case of Medicare services, cost, and right now it's cost plus 1%, is improved reimbursement over the prospective reimbursement rate that we're currently getting. So I do believe that there will be some improvement there.
There's a comment card on your tray there.
This says, if clinic can deny services to persons who cannot pay or have proper insurance, how will you remedy significant losses when they go to the emergency department? Now, that's a good question. So we don't deny services in the clinic, and do you want to come up and talk a little bit about that, Renee? What they're talking about here is patients that are turned away from the rural health clinic and end up going to the emergency department where the losses are greater. And actually, the truth is, we'd like to get patients out of the emergency department and into the rural health clinic where we get paid well.
I'll just speak a little bit to that, for some clarification. The goal is to try and keep the patient with us, especially if they're self-pay patients. However, here's what happens. If a patient continues to come in and they have 6, 7 visits and have not paid on any of those visits, we do at some point try to rectify the situation to get some of those funds back. Because even if they haven't paid at time of service, they're going to have a full bill sent to them, and it's bill after bill after bill. And we try our best to make accommodations for them, to make arrangements with our business office so that they can be seen still, so that they can make some restitution toward their bills and so forth. But the unfortunate thing is someone is going to have to pay for it. So it's either going to be on the clinic side or on the ED side. If we can, we try to make all accommodations to have them be seen at the clinic, because it is still cheaper for them to be seen at the clinic. But then again, that goes into the whole bad debt thing. Bad debt's going to fall somewhere. So it's going to either be on the clinic side or on the ED side. And our goal would be so that the patient would not have bad debt, so that we can make payment arrangements with them so that they can pay or do some restitution toward those bills that they're accumulating. But unfortunately, with the way the economy is right now, it's going to hit a department either way, and it's going to be bad debt either way if it's not paid. But it is our goal to try and make arrangements for those patients to be seen. We have 10, 12 patients sometimes, or 10 or 12 visits sometimes that have been unpaid by patients, and we do our best to still see those patients. But at some point too, we like to try and see if we can make arrangements for those patients to pay on their bills, because somewhere someone is paying for it. So that's the best answer that I could get. At this point, we try not to refuse patients, but at the same time, we really do try as well to have some restitution toward the bills that they do owe.
Thanks, Renee. Thank you. It's an excellent question, and it is exactly correct that we want to get patients into the family health center and into the rural health clinic and keep them out of the emergency department to the extent that we can. One of the things that we are going to be proposing to the county of San Bernardino and the AeroCare program is that they approve a rate for the family health center so that we can keep the AeroCare patients out of the emergency department and bring them into the family health care center as well. You have a question, sir?
Not so much a question, just a statement. I've had the pleasure of meeting you. I worked with Rudy and the board, and I'm the fire chief here in Big Bear. And as we deliberate about the hospital and what we want to do about the hospital, I think there's another effect that I at least want to mention, is the emergency medical services, the paramedic service. We run about 3,500 calls a year, so that's about 10 calls a day. As a service provider of the ambulance service, I need a place to be able to transport people to. If something would happen to our emergency room as far as that would affect capacity, it wouldn't be long before I run out of ambulances, because my only other possibility would be transport people off the hill to another receiving facility. So I just want to I have another engagement I have to go to, but I wanted to make that statement before I left. So a very good presentation thus far.
Thank you, Chief Willis. Thank you for coming. If there's no other questions, we'll continue on.
I was really happy to see that you brought up the article in Time, because I thought that was very sobering, that article. And I think we all understand that our hospital does not fall into the same category as the hospitals that they were bringing up there. I'm wondering if you found the rest of the article to be factually accurate.
I did. The article, the Time article talked about the fact that we're overspending in hospital care, and that the opportunities that are ahead of us in healthcare reform and other, as we try to reform the system, is really to try to move more towards Medicare and the discounts and the payment rates that they are currently paying. They talk about that ideally we'd be looking at a single payer plan, but says that's probably impractical in the United States because the insurance industry lobby is so strong that probably won't happen. And so the challenge that we have is to try to reform the healthcare system. They talked about taxing hospitals as a way to rebalance funding in the United States, and I think that is something that makes a lot of sense to me. I know that from the hospital side, what the hospitals will say is that the reason they charge so much is because they get paid so little by Medicare and Medicaid and the other government payers, and so where they have to make it up is through private insurance. However, it was kind of sobering, some of the profit margins that were mentioned in that article. Did you have other thoughts about it?
Sure. Actually, what jogged my memory is that, as you say, one of the things that the article was very critical of is how expensive some of these services were if you walked into a hospital and wanted to pay for them. And I thought it was interesting, the slide that you had up that was pointing out that the observation patient reimbursement rate was only 15%. And we can all agree that that's deplorable that they would reimburse us so little. But also, just to play devil's advocate, you could argue that we're charging the customer that just wants to pay for their services, we're overcharging them 85%. How would you react to that?
That's the trend of medicine. It's what I'm going to be talking about in a few minutes, is we're going to see less and less inpatient care, more and more outpatient care. So if we need to put our eggs in a basket, we need to put our eggs in the outpatient basket, not in the inpatient basket. We need to be prepared for the fact that there are going to be fewer and fewer inpatient stays, and that if we're going to sustain ourselves as a hospital and be a viable facility for the future, we need to be able to make money off of outpatient services, because it's not going to be there on the inpatient side.
Thank you.
Thank you. And thank you for coming too. Other questions before we continue on? Yes?
Yeah, on the Family Health Center thing, what is I know it's a $30 go in sub, and this actually did happen to me about a year ago. I had a blemish on my forehead that I thought was just a bruise, so I never went away. I went in there, they told me, don't worry about it, leave it alone, nothing. A month later, I actually got an appointment with WorkWire, the dermatologist, and it was actually skin cancer. What is the probability of misdiagnosis at the Family Health Center compared to a regular? Because I mean skin cancer, but I mean, when I found out what skin cancer, I was like, and the guy at the Family Health Center told me, don't worry, nothing, leave it alone. So, is
Okay.
that?
Sure.
Yeah.
Misdiagnoses unfortunately happen everywhere. I mean, they happen in the big hospitals, they happen in the small hospitals,
Yeah.
they happen in every practice. I can tell you what we're doing, which I think would help to avoid similar type situations in the future. We are going to talk in a few minutes about a telemedicine program that we're installing in the rural health clinic. The telemedicine system is a computer which is connected to a specialist somewhere else, either in the state or in the country. Dermatology is an excellent application of telemedicine. You can actually take a camera attached to a computer and put it on your skin and see the skin resolution more clearly than the naked eye.
Yeah.
And so we are going to be implementing a telemedicine monitor with contracts, hopefully for dermatology, so that for patients in the future
Yeah.
that maybe have a suspicious looking
Yeah, that's what it was.
mole, yes, that
And
we'd
they
be
told
able
me,
to.
don't worry, it's nothing, leave it alone, it'll go away. And it, like I said, the wife told me immediately cancer.
I'm sorry that happened.
But I'm still alive.
Yes.
You got all.
I'm sorry, and thank you for that. Yes.
Just to address that, I've been here for 15 years, and the mid-levels that operate out of the clinics have done an excellent job, because the patients would show up in the emergency room if there were misdiagnosis or problems. But when it comes to the mid-levels that we've had on top of this mountain, I don't think I've ever seen a better group.
Yeah. Other questions?
As you can see, we've looked at every possible angle of the money coming into our district as well as the money coming out of our district. We have looked at every penny and nickel, and we have thoroughly examined the operations of our district. This thorough examination of the financial resources of the district has led us to the next segment, in which we're going to talk about exciting plans for the reinvention of our healthcare district.
I've got a few more slides on what the healthcare district of the future looks like. Then we're going to talk about solutions and what we're doing about trying to reverse some of the financial downturn that we're experiencing at the district. There have been a couple of studies. The first one that I'm citing was done by the American Hospital Association a couple years ago. It's called Hospitals and Care Systems of the Future. It talks about a lot of the same things that Bruce talked about earlier tonight, and I'll just cover it very quickly because I know that it's getting late and people have lives to get back to. You will find tonight, as we're doing the presentation, that a lot of the things that are talked about in the American Hospital Association study on hospitals and healthcare systems of the future are the things that we need to be doing. They include clinician and hospital alignment, quality and patient safety. We talked about that under performance-based reimbursement a little while ago. Efficiency through productivity and financial management, and that's a key topic for tonight. Integrated information systems, which is our electronic medical record. Integrated provider networks, which is the affiliation opportunity, working with other hospitals. Engaged employees and physicians. I'm really pleased, by the way, to see the number of employees and the fact that many members of our medical staff are here tonight to be here to participate in this. I'm very glad about that. Shows engagement. Strengthening finances, payer-provider partnerships, scenario-based planning, and population health improvement, because in the future, not only is payment going to be based on quality, but it's also going to be based on population health and wellness. California Hospital Association has also recently done a study on hospitals of the future. They call it Transforming for Tomorrow. Some of the key hypotheses from that, I highlighted and read the ones that I really wanted to key in on. Primary care supply will require organizations to innovate the care model, in particular, the role of non-physician providers. We were just talking about mid-level providers a moment ago, and Dr. Fagan's comment about the fact that we're so fortunate to have very good ones here in this community. Also, the states, this is interesting, use this one. The state's rural and critical access hospitals are acutely vulnerable and without additional support could create access issues for patients and dilute margins of surrounding facilities, and integration will become more important than scale. The California Hospital Association they identified 4 types of hospitals for the future. They called them the innovator, the diversifier, the aggregator, the health manager, and the connector. The one that we identify most closely at as a small rural hospital is the connector, which focuses a service mix and direct extended care to other high-value providers. These others, the health manager is a Kaiser-type system that integrates care across the continuum. The aggregator is maybe a healthcare or HCA, Hospital Corporation of America, which owns and operates hospitals. The innovator is maybe a UCLA or a Cedars-Sinai that specializes in very specialized areas of care. And the diversifier is like a Dignity Health Catholic healthcare system that has several hospitals to spread their services amongst. The connector model is really where we need to be headed. And it says up here, the connector delivers a very narrow set of facility-based services and directs patients to the most appropriate site of care for other services through a network of affiliated high-value providers. In other words, it's going to be increasingly difficult for small hospitals such as ours to be all things to all people. We need to concentrate on primary care services and providing those basic life-saving services and primary care services that can be supported in a community like ours. And for the more specialized services, work with an integrated network of excellent quality hospitals and facilities to refer to, so that for those hospitals that, if you're going to have a specialized surgery, you probably want to go to a hospital that does a lot of them, does hundreds of them a month, rather than a hospital that maybe does 10 a year. So what we want to do is we want to connect up with those centers of excellence and larger facilities so that our population here in the Big Bear Valley gets access to the best care through a continuum of services and facilities working together. Any questions about that before we move on? And here's, I think, probably the part that most of you are here to observe tonight is what are we going to do about it? We've heard about all of the problems in our industry and heard about some of the challenges that we have locally. And I was asked very early on in the evening by Michael, tell us, give us the straight scoop and tell us what we need to do in order to preserve our hospital, because we all know that we need to have a hospital in this community. There's opportunities both on the revenue enhancement side as well as the expense reduction side. On the revenue enhancement side, I talked about telemedicine just a moment ago and the opportunity to provide dermatology through our family health center. There also is an opportunity to provide psychiatry. And we have identified an opportunity to provide rural health clinic, family health center visits through the family health center, through the favorable Medi-Cal rate that we talked about a moment ago, with the possibility of increasing our family health center revenues by $176,000 a year by implementing telemedicine in our family health center. We also have the ability to do it in the hospital. Telemedicine computers, kind of like this one in the picture, actually are used in hospitals today. They can be wheeled up to the bedside in the emergency department or in a hospital patient bedroom. It provides access to specialists from outside the local area. They could be anywhere in the country or anywhere in the world for that matter. Some excellent applications of telemedicine in a hospital setting are cardiology and neurology, where if you're a patient in the emergency department and you need to see a cardiologist or neurologist, or it's even been used for orthopedics, believe it or not, and many other specialties, we're able to wheel up the telemedicine unit, sometimes referred to as a robot, but not really a robot, and get a cardiologist or a neurologist who's able to look at the patient, talk to the doctors and nurses here in Big Bear Lake that are taking care of the patient, look at lab values and x-ray reports, and make a determination as to whether or not the resources are available right here to take care of our patients. There's two benefits to us. One is better quality care. Better quality care by having specialists come to the bedside. The next best thing to having more specialists that live right here in the area is to bring them to the bedside through technology. And that besides better quality of care is more revenue for our hospital if it turns out that we're able to keep those patients here with a consult from a specialist and not have to transfer them to a larger facility. The revenue opportunity in the inpatient and emergency department side is $372,000 a year we've identified by implementing the system. 340B pharmacy program is a program that critical access hospitals and sole community provider hospitals are eligible for. Essentially, it's government pricing for outpatient pharmacy drugs. If we were able to get government pricing, pay what the state of California pays for their outpatient drugs, we've identified we could save $60,000 per year, and we're working on implementing that right now. As Renee said a little while ago, we have recently added a pediatric nurse practitioner to our family health center. We're really pleased to have Suzanne on staff now. The addition of a pediatric nurse practitioner is also anticipated to increase our family health center revenues by $268,000 per year. And we talked about AeroCare and the contract with the county and the opportunity to improve our emergency services revenues by $100,000 a year. You add up all of those revenue opportunities and it's an additional $1 million a year that we intend to bring back into the district. We also have to do things on the expense side. As we've talked about and looking at models of hospitals for the future, one of the things that is very important is that we be a very efficient and productive and provide efficient as well as high quality care. Because we are in a financial crisis, and we talked about, you remember the bar slide that showed a $2.5 million loss this year, we are going to be implementing management furlough days, which I think we're all getting more used to. The state of California employees have had to do it, the LA County Unified School District employees have had to do it, counties and other employees, and unfortunately, we see it as a better option than cutting salaries or eliminating positions. Our first cut at trying to reduce expenses is implementing furlough days for management employees according to salary level, with the highest paid employees and highest paid managers in the facility taking the largest cuts, up to 2 days per month. We also, and Rudy alluded to it quickly in his report earlier on, we're having daily flash meetings with administration because it's very important that we staff our facility according to our occupancy levels and our activity levels and not overstaff the facility. We're having daily meetings with our clinical managers and we're going to start with our non-clinical managers as well, going through and getting a report by unit in the hospital of how many patients we have on the floor today, how many emergency department patients do we have right now, are we staffed appropriately for 5 patients or 2 patients or 1, or 50 patients in the emergency department or 100, and we're staffing accordingly. It's tough and it's difficult to do, but it's essential that we not overstaff, and unfortunately it's something that is a reality in healthcare. Actually, our nursing staff has been used to this type of thing. It's fairly common in the hospital industry we refer to it as flexing our staff when the census is down. When the census is down and we don't need as many nursing staff and support staff as we do when the census is high, we do flex staff, which means that we ask employees to either be on call rather than in the facility, or in some cases we ask the employees to take a paid time off day off rather than work during the day in order to save facility. And I have to say, I have been extremely pleased with the reaction and the response from our employees. I know it's hard because all of us rely upon our paycheck. We have a budget. We know what our monthly rent payment is and our car payment, and we know how much it costs to feed our family, so it's very hard to take extra time off. But unfortunately, with the downturn in activity that we've experienced over the last couple of months, it's very necessary. Does somebody have a gray Ford Escape, license plate 6PNK747? Your car is blocking another car from getting out of the parking lot. So you could take care of that. Gray Ford Escape 6PNK747. We're also going to be looking at contract positions. One of the areas where hospitals do tend to overspend and it needs to be looked at is contract positions. Oftentimes what happens is in place of employees, facilities bring contractors in. Sometimes it's for temporary staffing, sometimes it's for supplemental staffing. The contractors can be expensive, so we're looking at reviewing all our contract positions for reduction or elimination. As I said to our staff a week ago, we're all in this together, and we're all in this together, everybody in the room. That means our hospital staff, our management staff, our medical staff, our board of directors, we're all in this together. We all either swim together or sink together, and so we really have to look at every opportunity. As Rudy has said many times, everything will be considered and everything will be looked at, and so we'll also be looking at our medical staff contracts to see if there's any opportunity to renegotiate medical staff contracts in order to implement some reductions there as well. One of the toughest decisions we've had to look at is converting our surgery service to an on-call only service. Since November, we have not had a surgeon on call for the hospital, but we have continued to staff our surgery department as if we did. With the losses that we've sustained over the last couple of months, we can't continue to do it. It's a very difficult situation. I met with the surgery crew last week and told them that it's my hope that we will recruit a surgeon to be on call so that we can resume having an on-call surgery service. But as it stands right now, until we have a surgeon on call, I think we have no choice but to change the designation for our surgery department and staff it for elective surgeries only, and no on-call after-hours emergency service. And that means that patients will likely have to be transferred out if they come in after hours for emergency surgery. They have to be transferred out right now because we don't have that surgeon. We thankfully do have we just added a general surgeon who was on staff in the past. His name is Dr. Santos, who had patients here before and is coming back, has 3 surgeries tomorrow. We're happy about that. But right now, the only surgeons we have on staff are an ophthalmologist, a pain management anesthesiologist, and Dr. Santos, our general surgeon. So we need to build up that service, but right now we need to look at some cutbacks. And I know it's tough. I met with the surgery crew, and I know that means that we could lose some very good nurses because we just don't have the hours to offer right now.